Hello, I'm Dr. James Mercy. I'm the Chief of Endocrinology at Greater Baltimore Medical Center, and I'm the Medical Director of the Geckel Diabetes Center. I am also the President of Bay West Endocrinology. I'm going to start today to present to you the beginning of a series of presentations on the management of type 2 diabetes. This will be a case-based presentation and will be followed by two subsequent presentations by other members of our group. I'm now going to discuss the treatment of type 2 diabetes in the new onset patient. Remember, this is a case-based presentation. This program is designed to give the health care provider new insights into the current choices and guidelines for the treatment of type 2 diabetes. It will be case-based, and again, there will be subsequent programs followed after this program that you can also view at the same site. Our patient for today is a 53-year-old white male who presents complaining of fatigue and just not feeling well. He has a family history of diabetes and is concerned he may have developed this. He is overweight and has long-standing hypertension and hyperlipidemia. His current medications are lisinopril 10 milligrams a day and simvastatin 20 milligrams a day. He has been non-compliant with visits and has not seen you in more than a year. He has no significant past medical history. He does not smoke or drink alcohol, works in outside sales, and frequently eats fast food in his travels. At this visit, his weight is 235 pounds, he is 5'10", and his BMI is 33.7. Blood pressure is 142/84, his pulse rate is 76 and regular. Physical exam shows normal fundoscopic exam. His chest and cardiac exams are unremarkable. His abdominal exam reveals obesity but without any enlarged organs. His extremities reveal good pulses. A neurological exam is intact to monofilament and to normal reflexes. Based on this exam, you obtain the following labs. Fasting blood sugar is 185. A hemoglobin A1C is 8.4. Total cholesterol of 210. LDL of 114. HDL 36, triglycerides 220. Serum creatinine is 1.1, and microalbumin creatinine ratio is 15. At this point, you must decide what to do with this patient. Your treatment options include the following. You could send the patient for diabetes education. You could instruct the patient in self-monitoring and initiate medications in the office. Or you could simply say, you know, you've developed diabetes, you need to come back in about 3 months and see if you're doing any better. Our suggestions are based on current guidelines. This slide demonstrates the benefits of diabetes education on improved glucose control. This study was performed under the auspices of the American Association of Diabetes Educators. This was a randomized controlled trial in a primary care setting in which patients were randomized to education, evidence-based medication algorithms, and data was gathered. The patients were separated into those with high health literacy and those with low health literacy. As you can see on the two graphs on the right, the patients who had low health literacy demonstrated a significant drop in hemoglobin A1C from 10 to almost down to 7, and the control group had a much lesser drop. For patients with higher health literacy, the benefits were less clear-cut, but still benefited from education as compared to simply being given medication and not given any further information. The next slide, also from AADE, demonstrates the benefit of various approaches to diet control for diabetes. The three curves here show in control the blue line. As you can see from the blue line, the patients were brought in, simply told to watch their diet, and with the idea of developing diabetes, most patients will have some attempt to improve their dietary intake. However, this doesn't last, and you can see by 6 months the patient's A1C was rising back towards baseline. The black line showed the instruction on how to reduce carbs in diet. This also resulted in a drop in A1C early on, but then had a subsequent rise in A1C by 6 months. And using the plate method, which is the yellow line, the plate method is simply giving the patient a reduced size plate to put food on so that they are limiting portions based on plate size alone. And this seemed to have a better durability of effect in lowering the hemoglobin A1C. Once you have instructed the patients in adequate lifestyle therapy, meaning both diet and physical exercise, which I did not discuss here today, we then need to talk about choices for medication. There are two sets of guidelines which I will discuss today. The first of these comes from the American Diabetes Association in conjunction with the European Association for the Study of Diabetes, which is shortcutted as ADA/EASD. These set of guidelines start with the idea of healthy eating, weight control, and increased physical activity. And if that is not successful, the guidelines suggest proceeding to metformin as the next choice. Metformin has been on the market for many, many years. It has been generic in this country for many years, and its effects are well known. It has a high efficacy in terms of lowering A1C. It has a low risk of hypoglycemia. It is essentially weight neutral, and the major side effects are those of the GI tract, with nausea, vomiting, and diarrhea occurring in a fairly high frequency in the range of 5 to 10%. It is also very inexpensive. Metformin is typically started at 500 milligrams a week, titrated to a maximum dose of 2,000 milligrams a day in divided doses until the fasting blood sugar achieves a goal of 100. This titration can be achieved over the course of 4 weeks or to a maximum tolerable dose. If you're unable to achieve adequate control with metformin alone, the guidelines then recommend one of several other choices as the add-on therapy to metformin. The groups here are listed as sulfonylureas in the yellow box, thiazolidinediones in the purple box, DPP-4 inhibitors in the green box, GLP-1 receptor agonists in the blue box, and insulin in the gray box. I will discuss these in more detail one at a time. If you want to look at addition medications to metformin that are essentially weight neutral, these include DPP-4 inhibitors and GLP-1 receptor agonists. The DPP-4 inhibitors that are on the market now include Januvia, Tradjenta, and Onglyza. They all work roughly equally in terms of lowering A1C. Their efficacy is intermediate. A1C lowering, I will show you subsequently, but is in the range of 0.5 to 1%. They have a very low risk of hypoglycemia. They are weight neutral, and their main issue is they are of high cost. Side effects are relatively uncommon, the most common side effect being an allergic reaction, but I'm sure you might have heard on the news some concern about the increased risk of pancreatitis. This is still a not very well established risk. For GLP-1 receptor agonists, there are 3 on the market now. These include Byetta, Bydureon, which is Byetta once a week, and Victoza. The efficacy of these agents is fairly high. The risk of hypoglycemia is very low because of their mechanism of action. They result in some degree of weight loss, and the main side effects for these are GI, meaning primarily nausea with a little bit of vomiting as a concern. Again, the cost of these agents is high because they are all brand name. If you're looking for agents that avoid hypoglycemia, we can add to this list the thiazolidinediones. There is, in fact, only one thiazolidinedione on the market, that is Actos, which is now generic as pioglitazone. Pioglitazone has a good efficacy in terms of lowering A1C. Its risk of hypoglycemia is very low, but it tends to result in weight gain. The major side effects include edema and increased risk of heart failure. There had been some concern of bladder cancer in the past, but that seems to be alleviated somewhat by current data. And again, the cost is not as high as GLP-1s and DPP-4s because it is now generic, but it is not as cheap as metformin because it is still newly generic. The last set of agents that are included here as additions to metformin include sulfonylureas on the left. Sulfonylureas have been around for a very long time. They have a high efficacy in terms of lowering A1C, but they have a moderate risk of causing hypoglycemia. They tend to cause weight gain. The major side effect is hypoglycemia, but they are very low in cost. They also tend to result in beta cell burnout, and patients who go on sulfonylureas are often likely to proceed fairly quickly over a year or two to another agent because the beta cells are now no longer able to keep up. Over on the gray bar on the right is insulin. The original guidelines suggested insulin as the addition to metformin as a second agent. This is rarely done in clinical practice, but is certainly an appropriate choice for some patients. Insulin has the highest level of efficacy, the highest risk of hypoglycemia, is associated with weight gain, and the major risk is hypoglycemia, and the cost is variable depending on the dose that is required. If you're unable to achieve goal with first and second line therapy, you will need to proceed on to a third line of therapy, but this discussion will be deferred to subsequent presentations. And finally, you could add insulin as a last choice.
If you look at the agents that are currently available for treatment for diabetes as non-insulin therapies, you will see that they have relatively equal efficacy. Metformin tends to lower A1C about 1.3%, sulfonylureas maybe 1.8%, pioglitazone about 1.3 to 1.5%. Rosiglitazone is no longer available, so this is not worth discussing. Meglitinides, which are Starlix and Prandin, are about the same potency as sulfonylureas, although it's listed here as 1.1 on the average. DPP-4 inhibitors are a little bit less potent in the range of 0.7 to 0.8, and GLP-1s tend to be more like 1.2 to 1.5% drop in A1C. This will help you decide which agent might be useful for your patient as primary or as add-on therapy. The American Association of Clinical Endocrinologists / American College of Endocrinology has a different set of guidelines, but they tend to overlap a great deal. This slide is too busy to discuss in detail, and I will break it down on the next slide. This looks at treatment of diabetes based on baseline A1C. AACE guidelines also start with lifestyle modification, and if you have failed to achieve goal with lifestyle modification, if your A1C is less than 7.5, aiming for a target of 6.5, then any monotherapy agent is likely to be effective. These include the following as listed above. Metformin is, with a box around it, the first choice, but DPP-4s, GLP-1s, TZDs, even alpha-glucosidase inhibitors are all possible choices as monotherapy, and you may decide to choose the therapy based on your patient's blood sugar pattern. For example, if the fasting blood sugar is highest, metformin is most likely to be effective. If the fasting blood sugar is normal but postprandial blood sugars are higher, DPP-4s and GLP-1s may be more effective therapy. We could add to this monotherapy list a new agent which has just come on the market, which is an inhibitor of glucose reabsorption in the kidney, and this may be discussed in subsequent presentations. If you fail therapy at 3 months with either monotherapy, then you need to proceed to dual therapy, which is in general a combination of metformin plus something else, but could be a TZD plus something else if the patient is not tolerant of metformin. The most important point of this slide is the idea of clinical inertia. You must proceed on if the patient has not achieved goal in 2 to 3 months and not persist with single therapy when the patient is not making any progress. If the patient has an A1C of 7.629 at baseline, it is unlikely that monotherapy will get the patient to goal. Our patient today had an A1C of 8.4, and you might well choose to start this patient on dual therapy rather than monotherapy in an effort to get the patient to goal. Dual therapy is generally metformin plus a GLP-1, a DPP-4, or a TZD, or as a second choice, a sulfonylurea and glycinide, and AACE chooses these as second line because of the risk of hypoglycemia and weight gain. Triple therapy, again, will be discussed in subsequent presentations. For this patient, you have elected to follow the ADA-EASD guidelines, have referred the patient for diabetes education, and have started the patient on metformin. After 3 months, the patient has lost 5 pounds, checks fasting sugar only, with an average blood sugar of 120, and A1C is 7. The key to future care for this patient is to avoid clinical inertia. Your A1C has achieved 7, but maybe you are targeting 6.5 for a new onset patient, and a second agent might be required early on to get the patient to their target A1C. For new onset diabetes education to teach lifestyle modification and glucose monitoring is important to get the patient on track. You should then institute medical therapy following one of the sets of guidelines, either ADA, EASD, or AACE guidelines, and follow these along to make sure that the patient gets to goal by avoiding clinical inertia and achieving the targets that you have set for the patient.
Thank you for watching this presentation. If you have patients who need diabetes education, we will be happy to help them out at the Geckel Diabetes Center. We have readily available appointments at fairly short notice. If you have questions about your patient's diabetes, you may call the Geckel Diabetes Center or call one of the endocrinologists at Bay West Endocrinology. If your patient does not have insurance that is covered by the Geckel Diabetes Center, we'll be happy to come up with alternate plans for education. Thank you again.